Hello guys, this is Shahnawaz, and in this video you will see the lecture on the dysphagia, and I divided the dysphagia into two parts. This is videos about the part 1. Let's go and see what is dysphagia. We see that dysphagia is actually the difficulty in swallowing. We cannot swallow when we have the dysphagia. Look at this picture that when we do swallow, if it's water or any solid, we don't have ability to swallow. And actually, we should not merge the dysphagia with the global sensation. It is another difficult thing that is different from the dysphagia. So we see that the global sensation is actually when we even don't are swelling anything. We see that there is sensation in our throat, and we see that we sense a lump in our throat, so which through which there is no food transport limitation. And so globus is not related to swelling, but when we swallow, the global sensation is improved, unlike the dysphagia. We have two types of dysphagia, and the first one is oropharyngeal dysphagia, that is actually related to the hypopharynx, because we have some problem in the pharynx, like we have some neuromuscular dysfunction due to we cannot swallow the food. And we see that in the Zenker diverticulum. Look at this. This is the pharynx, hypopharynx, and we cannot swallow the food because of the diverticulum. Zenker diverticulum. This is the like a diverticulum out that is bulging out of the pharynx. This causes the difficulty in the swelling. This type of dysphagia is called the oropharyngeal. Actually, the oropharyngeal dysphagia hampers the start of swelling, unlike the esophageal dysphagia that we'll see further. The esophageal dysphagia, actually, the food is sticked after swallow, like in we see that in oropharyngeal dysphagia, the difficulty is initiating swallow. So the food is sticked after swallowed, like in the esophagia, we have the problem in the esophagus. So there will be dysphagia, we cannot swallow, and the food will be sticked in the esophagus. Look at this, the food is swallowed, and we have the esophageal narrowing, like a stricture, something like achalasia, or the webs or rings that cause the narrowing of the esophagus that make the swelling difficult. Well, we see here the oropharyngeal dysphagia in detail, like actually, the abnormality is related to the movement of a food bolus from the hypopharynx to the esophagus, like I discussed in a previous slide. The Zenker diverticulum causes the oropharyngeal dysphagia. This is the most common cause of oropharyngeal dysphagia. We also see others like causes, like if the patient has Parkinson's disease, so due to the difficulty in nerve transmission, uh, we cannot swallow. Actually, the oropharyngeal dysphagia, we see that the disease arises from the upper esophagus, pharynx, or upper esophagus esophageal sphincter, like UES. We will see that there is a difficulty, like if the sphincter is not innervated very well, or the stimulation is not very well from the nervous system, we will see the oropharyngeal dysphagia. So, when we have the difficulty in initiating a swallow, we experience that we can cough, the choke, the gagging, or nasal regurgitation. These things cause because of the oropharyngeal dysphagia. Like someone if had the zinc diverticulum, when he will try to swallow, suddenly he will experience the cough, the choking, or the nasal regurgitation. And in the next slide, we see the different causes of oropharyngeal dysphagia, like the neuromuscular dysfunction, as I discussed earlier, that this is the most common cause after the zinc diverticulum. When we have not the innervation to the upper esophagus, we see that we cannot swallow the any food. Some cerebrovascular accidents like past CVA or subarachnoid hemorrhage or subdural hematoma, like these may cause the difficulty in swelling, because of, in this case, we can see that there may be some muscular or some nerve problem, or amyotrophic lateral sclerosis. This may cause the innervation impaired that may cause the dysphagia. The Parkinson's disease also cause the innervation of the oropharynx impaired. So we see that there is less swelling. The myasthenia gravis, we see the acetylcholine deficiency due to which the muscle cannot contract or relax and may cause the difficulty in swelling. The dyskinesia, like when there is problem in muscle movements, we will also see the dysphagia in the oropharynx. And we see that further causes of the oropharyngeal dysphagia, as I told earlier, that the most common cause of the oropharyngeal dysphagia is secondary to neuromuscular dysfunction. The symptoms that may be more severe when swallowing liquids. For the assessment or for the approach to the oropharyngeal dysphagia, we must ask questions about the neurological signs and symptoms. For example, if the patient has past history or the present history of Parkinson's disease or myasthenia gravis or like this. In this slide, there are some causes that are not more common. Rarely we see structural abnormalities. For example, cervical osteophytes. We see the bony tissues in the pharynx and the Zenker diverticulum, as this is the hypopharyngeal reticulum. In the hypopharynx, we see that there is a bulging. Some tumors, like cervical tumors, if arises in the bones, we see that it just enter into the esophagus. The post-cricoid webs, we see the cricoid bones. This bone also meets the webs, and when we note difficulty with a food that is a solid, when we also say that this is the oropharyngeal dysphagia, because mostly the solid food cannot enter into the esophagus when we have the oropharyngeal dysphagia. So we need to assess the oropharyngeal dysphagia. The best thing to assess the oropharyngeal dysphagia is the video fluoroscopy, that is also called the modified barium swallow. That makes to know us that what is the problem in the pharynx, or do we have some neuromuscular dysfunction, or do we have the zinc diverticulum, or like this. This is like a video when we there is barium swallow, and we see that in the video we can see everything what's happening in the hypopharynx. Video fluoroscopy not only helps to confirm the presence of oropharyngeal dysfunction, but it can also assess the degree of aspiration. For example, how much food is being swallowed and how much food is retention in the pharynx. Now I have finished this part. Thank you. See you in the next part. Bye bye.